Okay, without further ado, good morning. Happy Saturday to all of you joining from, different parts of the country. So good morning, good afternoon, and good evening, depending on where you're joining us from. My name is Delaney Hines. My preferred pronouns are he, him, and I have the pleasure of serving as not only today's moderator and host of our Learning for Life session, but I also serve as a member of the board of directors at SCAGO, along with the chair for education committee, and also one of the co-chairs for our upcoming Sickle Cell Disease Summit taking place on August 23rd and 24th. So as I mentioned today, I will be moderating today's session. If you or members of your network would like to refer to the information shared in this session at a later time, as you know, today's session will be recorded and we will post it on our website, sicklecellanemia.ca, for viewing at your convenience. One of our missions at SCAGO is, as you can imagine, to serve not only as a conduit for members of our community to access evidence-based, up-to-date information like we prepared for you this morning, but today's session is important because we all appreciate that the transition from adolescence or pediatrics to adulthood comes with a number of considerations and a number of challenges that at face value may not be apparent. So we're hoping that the speakers we have reflected in our panel and who you can see on our screen will be able to offer some insight as well as some really, good tidbits and tips that you can carry forward as you also navigate that stage of your life, or if you're supporting someone who's navigating that stage of your life. So we have 2 hours to kind of unpack it from a variety of different vantage points. And as well, we have about 30 minutes towards the end of the session for you to submit any questions or any comments that you would love to have our panelists respond to. So you can see on my screen, alongside on your screen, in terms of the videos that have been enabled, we have 4 lovely guests joining us today. I'll be introducing them very shortly, but I want to make sure I did a bit of housekeeping before I got into that. So, we've already went through our welcome and acknowledgement. Going to share with you just a bit of housekeeping rules. Then we'll have each of our panel presentations. Sorry, but the question marks, a bit of a typo there. And then after that, we'll be able to have you ask any questions. So we do ask that you save any of your questions, thoughts, or concerns until the latter portion of our session, where our guests will be able to answer your questions individually. We also kindly ask that you respect the learning being done in this space by abiding by the following housekeeping rules. So 1, you'll have noticed that your microphones have been disabled for the duration of the webinar. If you'd like to ask a question orally, or you can either raise your hand using the hand raise function, or you can make that point known in the Q&A and we can go ahead and unmute you. But probably the more efficient route would be to use a Q&A feature, so you can capture your thoughts throughout the session and then just insert your questions there. And we'll do our best to try and answer all questions throughout the session. Closed captioning is provided for those of you who require that feature. We also ask that, it kind of goes without saying, but please use respectful language in the chat. So no profanity or inappropriate images or any posts unrelated to today's session. Please don't post any other material as well. We have a different forum for that kind of conversation, so we want to keep it specific to today's content. And as usual, please keep discussions and comments on topic as much as possible. So I do want to make sure that we take a second to recognize our own responsibility and obligation to acknowledge the land in which we are all joining today's session from. I currently am grateful for the opportunity to gather through this virtual medium on this land, and we thank the generations of Indigenous people who have taken care of this land and long before other nation and other groups from different parts of the world arrived. In particular, we acknowledge the traditional territories of the Ojibwe, the Anishinaabe, and the Mississaugas of the New Credit, all covered by the Upper Canada Treaty. We also recognize the many nations, First Nations, Inuit, Métis, and other Indigenous peoples who have made and had a part to play in shaping and strengthening not only this province, but this country. And we also need to continuously recognize that we have an obligation to educate ourselves about not only the colonial history of the country, but understanding that some of the past impacts are still having reverberating effects to the present day. And there are a number of different disproportionate burdens impacting Indigenous peoples that we can all play a hand in hopefully remediating. So, without further ado, I want to take a second to introduce our first speaker, but I'm going to also just introduce her co-speakers who are also with her joining us today. So, up on my screen, you'll see we have Dr. Susan Williams. Dr. Susan Williams completed her Bachelor of Science at McMaster University. I won't tell you what year because that might date her, and I don't think she wants me to do that. She completed medical school at U of T following her undergraduate degree at McMaster. She completed pediatric and pediatric hematology oncology training at McMaster University. Following that, she sorry, my computer's glitched. She joined the full-time faculty in the pediatric hemostasis program in the section and division of hematology and oncology at the Hospital for Sick Children. She's currently a clinician specialist in the Department of Pediatrics and associate professor at the University of Toronto. She completed her Master of Science in Health Research Methodology at McMaster University in Hamilton, Ontario, and also a Master of Science in Hemoglobinopathy through the University College London. Her clinical and research interests are in the areas of thrombotic disorders, sickle cell disease, and stroke. And she's currently the Education Training Program Director for the Sick Kids Pediatric Hematology and Oncology Fellowship Program. Following her, we'll have Stephanie Haskett, who you see on the screen. She's a clinical navigator in the hemoglobinopathy lifespan program at London Health Sciences. She's been a nurse for 9 years with a primary focus in patient advocacy and education. Stephanie joined the London Health Science Center in the fall of 2023 and has worked to develop a transition program for patients with sickle cell disease and thalassemia. She supports both pediatric and adult patients in their journey with sickle cell disease with a focus on youth and young adults. Next, but up we have Julia Millington. Her pronouns are she, her, and she serves as a social worker and transition program coordinator for student accessibility services at McMaster University as well. Her work focuses on expanding access to and preparation for post-secondary students with disabilities. Through empowering conversation with students, families, educators, and healthcare professionals across the Golden Horseshoe region, Julia helps students realize what is possible. At MAC, she leads the MAC Start Summer Program, which provides academic skill building content, social opportunities, and peer mentorship for incoming undergraduate students with disabilities or living with disabilities. Her commitment to advancing inclusive practices has led her to be a sought after speaker, as you can all see demonstrated today, at national events such as the Accessibility and Inclusion Summit, the Canadian Association of College and University Students Services Conference, and the High Incidence Disabilities Conference. She lives in Hamilton with her family, and we might see some of the newer members of the family pop up. So that would be a special guest appearance if they do. And she inspires to create a more inclusive world. And last but certainly not least, we have Fitz-Ann Howell, a longstanding member of SCAGO and one of our leaders in our patient advisory council. She's a sickle cell patient advocate who has endured her handful of struggles and overcome many of them. She's overcome these things through her determination and her fight to make a change. She has always been an advocate for those who need it, and what better place to do that than SCAGO's very own Patients Advisory and Advocacy Council. She has been a member of the PAC for a few years and has loved their work so much that when offered the position of PAC chairperson, she couldn't pass up the chance. With PAC, she has also been able to receive her massage therapy license, where she aspires to help the sickle cell community heal using a more holistic approach. I know I've been belaboring the point. I've been talking a lot. There's only one final point I'd like to make to folks. Just one final disclaimer that remember that the information shared today does not constitute medical advice and is shared with you for information purposes only. No materials shared with you today are intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare providers with any questions you may have regarding your medical condition or treatments and before undertaking any new healthcare regimen. So please do not disregard professional medical advice or delay seeking it because of something said during this webinar. Okay, that's all from me. I'm going to stop sharing my screen now, and I'm going to hand the microphone over to our guest, Dr. Susan Williams, where she can take us through her prepared remarks. Over to you, Dr. Williams.
Thanks, Delaney. So I'm just going to hopefully successfully share my screen again.
Almost there. Right now I'm seeing a black screen.
Left.
There we go.
Just let's see. Let the show on the road. And
Almost there.
so I'll just have to go to slideshow.
One more.
Are we
And
there?
we are live.
We have launch. Okay,
We
all
have
right,
launched.
perfect. Okay, sorry about that, everybody. So I'm going to talk a little bit about the clinical side of transition from pediatric to adult care in sickle cell disease. So just to start off with a little bit of background. So sickle cell disease has had an increasing lifespan over the last 100 years or so, so the last century, which are shown in the graph on the bottom there. So because the treatment of complications and preventative care have really increased the lifespan for patients with sickle cell disease, the vast majority of patients with sickle cell disease now live well past 18 years of age. And you can see again in the pictogram on the bottom there, sickle cell disease going back to sort of the 1910s in terms of the life expectancy being under 10 years of age, and the increasing life expectancy that has occurred over the last century, particularly tied to some of the major revolutionary things that have happened in sickle cell care, including preventative penicillin, use of hydroxyurea, and transfusion for stroke prevention. Of course, the life expectancy is not reached what would be standard for unaffected individuals with sickle cell disease. You can see all Americans across the top. This was American data there, and that's been steadily increasing. But it's nice to see the dramatic jump that has occurred in sickle cell disease, and hopefully will continue to occur over the next number of years. So what I just showed you was US data. If we look a little bit closer to home, we don't have the richness in terms of length of collected data on mortality for sickle cell patients in the country. But if we look at what has been published, this goes back to 2007, looking at birth rates and death rates for individuals affected with sickle cell disease. And you can see our data certainly in the last, say, 10 to 20 years seems to be relatively stable. And there doesn't seem to be this dramatic increase. And that's probably reflective of a lot of the positive impact in reducing mortality is already incorporated in the data that we're seeing in the Canadian set. The age at which patients transition can vary from program to program, but for the most part, it's typically between 18 to 22 years of age. And that timing of move from pediatric to adult care health system is associated with an increased risk of death for sickle cell patients. On the left-hand side, there's a bar graph showing mortality rates in the different age groups. So the first bar is showing mortality rate in 0 to 5-year-olds. The second, sorry, jumped a little bit. The second in 6 to 11-year-olds. You can see the drop off from that early childhood and mortality rate to being relatively protected from mortality in the 12 to 18 years. And then this increase that you see once you age out of the pediatric age grouping into the 19 to 29 and above 30. And this phenomenon has been present throughout the historical time that we have captured mortality outcome on sickle cell disease in the US. So on the graph to the right-hand side, you can see a percentage of deaths by age again across the bottom. So less than 1-year-olds were at the far end, and then the elderly individuals across at the right-hand side. And the dashed line is showing the data for 1979, the solid line for data from 2006. Two things that are notable. So in 1979, there's a big hump in that dashed line data at 1 to 4. So there was this early childhood mortality, drops off again, and then this increasing rise in young adulthood. With the improvements in care that I touched on right at the very beginning, you can see we've basically ablated the early childhood loss, but we didn't ablate that young adult loss, unfortunately. What has happened with the improvements in care has shifted it slightly later in time, so the curve is slightly later, but still there's this incredible increase right around that young adult stage. And this is in part due to sort of the change in the evolution of the disease. So it's gone from being a disease where children died to now it's a disease that, for the most part, children don't die, and they're living into adulthood, and now they're living with chronic disease. So rather than dying of acute complications that you can see on the left-hand side, so this bar graph is showing the contributing causes to sickle cell-related deaths in the U.S. You can see big numbers for acute cardiac, acute infection, acute pulmonary disease on the left-hand columns there. And it's year data again. So the darker blue is older data, to the orange being the most recent data from 2010 to 2014. And what you can see is this increase. So the orange line, or the orange bar, being higher in number for those chronic conditions. So chronic cardiac, chronic pulmonary disease, having a larger contributing to cause of death. So all of that is important because it'll really tailor and guide what we need to do and how we need to do it to optimize outcomes for patients with sickle cell disease as they move through the different phases of life, if we group it by age. So at the institution I practice at, we have a large pediatric sickle cell clinic at Sickle, and our partner institution is literally across the street. It's a 3-minute walk, 190 meters away, where the red cell disorder clinic at Toronto General is. But really that short distance is short in physical distance, but they really can at times seem to be worlds apart. There really is a lot of differences that occur from the pediatric world to the adult world in healthcare, but some of the things that can impact on care of patients with chronic diseases certainly will include the sort of perspective of the care providers. So in the pediatric world, we're very family-centered in terms of decision-making and information sharing. That family-centeredness doesn't go away in the adult world, and families are definitely included, but it really does shift to very patient-centered decision-making rather than the family being the network that's automatically being gone to first. At SCAGO, or in most large pediatric centers, specialty care is happening all under one roof. In the adult world, that often is unfortunately not the case, and so the other visits that need to occur outside of the hematology clinic are often in different locations. So there's more travel and coordination involved in getting to those visits. We tend to have, in the pediatric world, fewer appointments that are longer in duration, and the adult world tends to have more appointments that are shorter in duration. And this can lead to sometimes this feeling of being rushed through the system. In the pediatric world, we tend to mother or father our patients and families. So we do constant reminders about your appointments and medications. We call you, we email you, we reach out in many ways to ensure that people get to their appointments. And in the adult world, the responsibility is shifted to the patient and the individual who's an adult and capable of making adult decisions and following through. So some reminders are given, but really patients are expected to monitor their own appointments and medications and present themselves when there are issues. So some of the concerns that are often expressed by patients prior to transition to adult care include leaving this comfortable pediatric setting that is all you've known for the care that you've had so far. So going to a new place, potentially getting a physician who may not be familiar with sickle cell disease if you're not going to a partner institution with a comprehensive sickle cell program. The questions around, how does the family support change? Will my parents allow me to become more independent? How will I pay for medical treatment? And this is not so much for the core hospital-based medical treatment, but things like medications or adjunctive things that are not necessarily covered under OHIP. Will I be treated as an adult? Will the adult providers understand how sickle cell disease has impacted me as an individual? And will they believe me if I'm in pain and expressing how I feel? So healthcare transition is important to address those concerns, and really what it focuses on is a very structured approach to prepare, transfer, and integrate these young adults into adult care, young adults and adolescents into adult care. So empowering them with skills and knowledge to be able to navigate the adult healthcare systems, which can at times seem far more challenging, I think, than the pediatric system, and become your own self-advocate. So knowing how to speak up for yourself and speak loudly is a really important skill that hopefully has developed throughout the pediatric care, but definitely needs to to continue to develop once you get over to the adult side, and really spans over several years. So it's not a once and done phenomenon, and certainly does not end when the patient arrives in the adult healthcare setting. So walking through the doors of the adult clinic is not the end point of the transition or transfer, and it's an ongoing process. Important as well is that we're targeting both the patient, the provider, and the healthcare system. So it's not just about how we help the patient, but how we help the family, and also how we help the providers that are going to be incorporating and helping patients to care. Families need to learn how to best support the patients, and that may be very different from what was done as a child, as an adolescent. That's going to change. Everyone needs support, but how that's manifested may need to grow and modify. Providers can assist our patients and families to set up and meet goals, and this transfer transition growth process is a priority for all adolescents and young adults with a chronic disorder, but particularly for those with special healthcare needs and those with cognitive impairment who will need even more support in going through this transition process. So on screen, I'm sharing the approach that we've developed or we've adapted to what we have at Sickle, because we do have the luxury of having a transition navigator that can assist with the transition process. And I think the idea of the transition navigator, as wonderful as ours is and the wonderful work that we do, is not necessarily about having a transition navigator at every single center that's going to look after patients with sickle cell disease, because that may not be feasible, but incorporating the tenets and the aspects of what transition care involves in whoever is the functional transition navigator participating in the transition navigation for that patient. So there's this process of preparation, which starts when the patients are young. We start at 12 to 16, and some would say it should start right from the get-go. So right as soon as the patient joins the clinic, they should be learning how to be a self-advocate, how to learn about your disease and be comfortable talking about your disease is something that continues throughout childhood. The transfer clinic for us occurs around age 17 to 18, and then the first appointment in the adult care center will occur after 18 years, and then we continue to have this post-transfer support at our center for 2 years after the arrival to the adult center. So as challenging as it is important to try to get it right or close to right, because we know that emerging adults with sickle cell disease who do not successfully transition will have increased acute care utilization. So be in hospital more with inpatient admissions, will be using the emergency rooms more frequently, will have worsened disease severity, and are at risk for early death. So on top of the risk for early death, that's already there by nature of the disease. When there are gaps in transition from pediatric to adult care, this is associated with all of the things that I just touched on. So this is a visual summary from a recent publication looking at a US hospital transition program, which showed if you broke patients out into those who transitioned quickly, so less than 2 months, comparing them to those that transitioned at longer gap times, so 2 to 6 or greater than 6 months, and whether you looked as was shown in the red dotted line in the first 2 years after transition or the solid blue line up to 8 years later, when you look at inpatient encounters, it increases as that gap in transition increases. If you look at emergency department encounters, they increase as that increasing gap of transition increases, and outpatient encounters decrease as that increasing gap in that transition from pediatric to adult will increase. So patients use the outpatient services less and become more dependent on the inpatient and emergency room services, all of which are negative things in portending poor outcomes for patients. Living as an adult with sickle cell disease is challenging. Living as a child with sickle cell disease is challenging. And it's not only about the physical aspects or the clinical aspects of the disease. So many other things impact and interplay with that, from the impact of relationships, school, all of the employment, the outside things that impact our health, worrying about access to care, worrying about the ability to pay for care, access to insurance, not feeling that you can trust a physician because they don't have the knowledge or may not have the knowledge, or may be uncomfortable in caring for sickle cell disease patients. There's lots of good data from the US that although sickle cell care does not have to be solely dependent on a hematologist, there may not be that comfort with looking after sickle cell disease in other physician subtypes. So a survey that was done as an example, looking at internal medicine physicians who were asked about their comfort level with looking after sickle cell disease, and 30% said they would be uncomfortable with looking after patients with sickle cell disease. So again, challenges in terms of connecting in the right way to healthcare providers that are willing, interested, and feel capable of providing care. We have, though, identified facilitators to successful healthcare transfer and transition. So if you're fortunate enough to be in a center that the adult and pediatric programs are in the same hospital, that is fantastic and does lead to better outcomes. Having an SS genotype is associated with better outcomes, I think largely because the work to date has focused on SS patients, less so on SC patients or other subtypes of sickle cell disease. And if you're receiving sickle cell disease modifying therapy, you also tend to have better connections with ongoing healthcare and have better outcomes as a consequence of that. So lots of barriers that we can talk about. They're listed there: institutional bias, practitioner bias, inequity in patient lives, access to medical care, how complex your disease is, patient perceived lack of knowledge of the transition process, challenges in care coordination, particularly when there are multiple care providers that need to be coordinated in care, and having limited access to ability to pay and insurance access, as I've touched on. But that really speaks to the need for all the interventions that need to be developed and implemented in the transition program so that patients and families can really feel prepared for transition. As I've touched on at my institution, we do have a transition navigator, and they have been shown to improve transition readiness, reduce loss to follow-up, and improve medication adherence. I'll share just briefly our data where we looked at our patients that were transferring or transitioning to adult care. And we looked at patients right before we introduced the transition navigator and collected data on patients a year before they had their final pediatric visit and a year after they had their first adult visit. And then we compared our data pre-transition navigator in red and post-transition navigator in green. And if we look at patient retention in the adult care system, we had much fewer loss to follow-up when we had the transition navigator. So we lost 11 out of 38 patients pre-transition navigator to ongoing adult follow-up, and only 4 out of 57 once we had a transition navigator in place. When we looked at medication adherence, which will tie to clinical outcomes, the transition program was independently associated with improvement in medication adherence. So looking at patients who were adherent to their sickle cell disease modifying therapy for greater than 4 days of the week, pre-transition navigator was 8 out of 14, post-transition navigator in green, it was 23 out of 25, and statistically significantly different. So the interventions that we developed to prevent these gaps between pediatric and adult care will help address some of the barriers to transition and increase the comfort with adult providers and facilities for the patients and families, allow early introduction of adult care so we don't have patients being lost to follow-up for a number of years, and then coming back into adult care with potentially more development of chronic complications of their sickle cell disease. We want to improve their health literacy and really promote this patient self-efficacy and self-advocacy. And as well, touched on the patients that do have neurocognitive deficits are a unique and special population that we need to pay very special attention to. So some of the sickle cell transition recommendations that are out there really summarize that. So transferring skills, increasing self-efficacy, coordination, transferring knowledge, linking to the adult services early and in multiple ways, and as well making sure to access readiness or evaluate readiness for transition. And to end, I'll just touch on the future needs that we have to continue to improve this transition process for our patients and family is really to understand the experiences and barriers that adult patients are having. Because I think what's happened a lot in the literature to date and the way we've approached it has been very pediatric focused with adult partnering. And I think that needs to improve, and we need to get more feedback from the people that land safely or don't land safely in adult care as to how we can make things better and really make no assumptions. And we need to be asking our patients and families and the providers that are involved in the care what can be done to help make things better and incorporate all of those perspectives into improving this transition of care. So I'll end with that. And again, like the big tips, being a consistent self-advocate, knowing about your disease, and being a loud advocate for yourself are so important in being heard and listened to all throughout the span of the disease. And I'll stop there.
Thank you so much, Dr. Williams. Words of wisdom to close out your section of the presentation today. No, that was fantastic. Folks, we are only just getting started. I'm just going to introduce really quickly our next speaker, who's going to give you more of a personalized London Health Sciences experience. So we have Stephanie Haskett, Clinical Navigator at London Health Sciences Center, who's next up on the docket, who'll be discussing transition from her lens as a clinical navigator. So Stephanie, I turn the screen sharing privileges over to you.
Thanks so much. All right. Can we see my screen?
Yes.
Perfect. Thank you. So as Delaney had mentioned, my name is Stephanie. I'm a clinical navigator at London Health Sciences. And so with that, I have a primary focus in transitioning patients with sickle cell disease and thalassemia from pediatric to adult care. So I just want to make some acknowledgements because I have a fantastic team that I work with that supports this particular population. And we are really lucky. As Susanna mentioned, we are actually a lifespan team, meaning that almost all members of our team support our patients throughout their journey. The only changes we have within our program are our physicians themselves. So these are just a list of the wonderful people that help support the work that I do, as well as support our patients in London. So quick outline of some of the things I'm hoping to go over today. Just basically outlining what is transition and what does that look like in healthcare, and particularly sickle cell disease, barriers to transition, transition elements and timelines, why a personalized transition experience is important, tips and tricks to be successful in that transition, and then particularly post-secondary with sickle cell disease, and then tips for success at post-secondary. So we first start off, we talk about what exactly is transition. So simply put, it is that shift that you make, and it's moving from a more child and family-centered approach to care to a more adult and patient-centered focus of care. So when transition occurs, as previously mentioned, most times it occurs around the age of 18. Unfortunately, there are some rules and regulations that exist in terms of why it has to happen at 18. When we look at research and data, ideally it should be a more individualized approach that transition happens when that particular patient is ready for the transition to occur. And not everyone will be ready at 18, but within our healthcare system, that is when they consider people legal adults, and that's usually when the transition occurs there. When we look at an 18-year-old and the aspects of their life happening at that time, there's many transitions that are occurring. So we look at the educational ones, going from high school to a post-secondary, or even into career or apprenticeship, those types of things. They're learning more age-based responsibilities in that. And this is a lot of alterations to consider when we look at this big transition. So we look at the two terms, transition and transfer. So transfer is actually like what is happening. The care is being transferred from that pediatric physician to an adult physician, but the transition is actually the process that's preparing them for that transfer. So it's more purposeful and planned. It's more outlining the skills they need to be successful when that transfer occurs. So again, there are barriers that people face when they're making this transition, and particularly our sickle cell patients, the barriers they face. So barriers fall into usually about 5 different categories. They fall into relationships, access and insurance, beliefs and expectations, knowledge, and skills and efficiency. So when we look at relationships, that relationship is, again, like Susanna mentioned, the strong relationship that is established with the pediatric team. These are people who usually are with you throughout your journey with the sickle cell disease. So some of people, that is as a newborn, when you've screened positive on a test, or when you've come to that particular clinic. And so there's long established relationships that are difficult to let go of, as they are a pillar of support in a lot of people's journeys. And then we also look at like, what other relationships do they have? Good relationships outside the healthcare system to support them and encourage them when making this major transition in life. And then accessing the services. So what are the barriers to accessing? Is it location of services? So for some, it isn't as closely located to their home. And so how is that getting there? How is it, even just wait times and things like that? Usually there are, I know in our particular center, a bit more of an increased wait time in our adult center than there is in our pediatrics. And then insurance coverage concerns, and particularly when it comes to medication, we lose a lot of patients to being able to follow their treatment plans because of insurance issues, and it's a complex situation to navigate. And then what are their beliefs and expectations? What do you feel about transitioning to adult care? What experiences have you had? So whether it's a negative experience in an adult emergency department, or again, just the people and others that you're working within that system that are affecting that belief that you have. And then the knowledge piece, which is a big aspect that we try to educate patients on to be as successful as possible. So if you have limited knowledge about the disease process that you have, so sickle cell disease, and the treatment you're receiving, medications, or the transition process in general, you will be less successful in that transition. And then the skills, are you able to be independent? We talk about the term self-management, which really means understanding your personal responsibility. So do you understand your personal responsibility when it comes to your sickle cell disease and how to care for yourself and make yourself successful? So I, in particular, when I'm working with patients, focus on these really 3 big phases. So we look at the preparation phase, the handoff phase, and then the immediate post-transfer phase. So with preparation, that's when we're building all of the skills to be successful in the handoff phase. So we talked about health literacy, which is learning to access, understand, and use the information services when you're making decisions about your healthcare. So do you know what medications you're taking, why you're taking them, and what dose? That's a big aspect of health literacy. What are the complications that you have experienced with your sickle cell disease, and how does that impact your everyday life? We're working at increasing independence. So when we look at that approach from more of a family-centered approach to an individual, we look at skills to increase that independence. And then the handoff is that transfer part that I had talked about. So it's meeting with the clinician prior to transfer and making sure that they know all aspects. So in healthcare, sometimes we really get focused on the medical aspects of that care, but it is really important to look at the individual as a whole person. So besides medical, what is happening with psychosocial needs, vocational, and we talked about like schooling, and also like the social supports that they have, because these are all aspects that will impact their care moving forward. And then it is really important to not just kind of drop patients after they've done this transition. There's a lot of unknowns, and so being supported there is really important. So I know some centers support till 20. I'm lucky enough with my lifespan program, we support to 25, particularly with transition. But with my role, I'm there throughout, and there's that established relationship that we're really lucky. But we 525 because not everyone is going to post-secondary right at 18, and they may still need continued support throughout those years as they establish themselves. So when I am working with people to create their individual transition plans, you have to look at all aspects. So psychosocial, emotional, vocational, and medical, because these are all unique. No two patients with sickle cell disease are going to have the same transition plan, and it's really important that when I work with them, it's individual based on their needs. So when I look at it, I look at different areas when we assess the readiness. So the medical, again, what is your general knowledge of sickle cell disease? Do you understand what it is, how it impacts your body? We look at also the genetics. Do you understand the genetics and how that will impact future relationships in terms of your decision making and processes like that? What is your established pain management? How are you currently managing your pain? And how do we help make that so it's not impacting different areas of your life? And then what is the adherence to treatment plans or medications, things like that. The social domains. So again, family functioning. What is your relationship within your family? Are there supports there? Your peer relationships, and then drug coverage, those types of things. Emotional. So what is the maturity level of the individual that we are transferring? Again, like I said, when we transition, it happens at 18, but not everyone is fully ready. So what supports do we need to provide based on the maturity level of the individual? What is the self-efficacy skills that that person has, their cognition, different aspects that might affect them. And then in terms of academic and vocational, so what are your academic plans? So I work with individuals and do like interest surveys when they're young teens to kind of help direct them towards the path of whatever they need to be successful in education. And then any vocational rehab, we're lucky enough to have educational liaisons that we work with at our hospital to support these individuals. So this is the specific kind of timeline that we work with. So starting at the age of 12, we encourage individuals to learn more about their health condition, medications, allergies, and to ask questions about their health, to be more active in that process. As we move into more the teen years, 14 to 15, 16 to 17, we look at skills such as carrying your own health card, learning what to do when you have to seek emergency care, practicing filling prescriptions, making appointments. So that's actually something that within my transition program, when I work with individuals, I do what's called like a skills lab, where we practice in a setting, making a phone call to refill a prescription. So I have another staff member that we practice that with, making appointments, because the more you get exposed to these experiences, the more successful and less anxiety you may have moving forward when completing them. We talk about privacy and how that changes. Again, touring the new practice locations so that it's comfortable and it's not a new area. And just like keeping a medical summary so that the individual is aware of what's happening. And so, as said previously, it goes all the way to the age of 25. So when we do this education, what are some things? So describing their own medical history, refilling medications, making appointments, utilizing health insurance, emergency plans, and speaking up for yourself, which is easier said than done. So there's also basic things that I work on, like time management and natural consequences. So what are the natural consequences if we don't take care of our health? What does that look like in the future, so that these individuals have all the knowledge and power to decide what is best for them? So important steps. There are many transitions happening at once. So you might be moving away to school, you might be developing yourself as a young adult, post-secondary, lots happening. So just being self-aware is really important when you're handling that. And then you're navigating the healthcare system, scheduling appointments, refilling medications, trying to communicate effectively. It requires a lot of proficiency in planning, problem solving, and articulating symptoms. And so I always say to give yourself a bit of grace, because that doesn't happen overnight. It happens through experience, and as long as you have those supports along the way, that's what's really important. So tips to keep you successful in that transition: knowledge is power. So as much information as you can, which is hard sometimes to want to seek out that information, but the more you know, the better you understand what's happening and the better you can look after yourself. Plan ahead and prepare for potential stressful events. As we know, stress can sometimes impact sickle cell disease negatively. And so if we know how to take care of that and manage stress, it will be helpful. And then being involved when creating that transition plan. So obviously I can create it and make it as much individualized as possible, but it really is unique to you as a patient. And so being involved is a huge aspect, and reevaluating. So the transition plan that's created at 12 and 16 aren't going to necessarily be the same, because that person is evolving and aspects of their care change. And then taking it step by step, moment by moment, breaking it down into small manageable pieces, and pat yourself on the back for the steps accomplished. This is a journey. It starts young, and so being proud of what you've accomplished throughout that journey is really important. So now I'll take a little bit of a switch of focus to more so post-secondary in sickle cell disease. So this is obviously a very thrilling time in many individuals' life. It signifies a change of you as a person, and increasing independence, which can also come with that heightened level of stress. So patients with sickle cell disease encounter distinct stress factors that may not be familiar to peers that are also going through this post-secondary transition. So therefore being prepared is essential. And that's what I'll kind of talk about, is being prepared for that process. So most important to continue moving towards your goal, and just being thoughtful and flexible in that approach when planning the transition. So I'll start first by looking at when you're applying to school. So for some, that may start in the fall, some maybe a little bit later, but we look at what a good school is a good school that's a fit for you. So you have to look at, do they have the supports in place that will be beneficial to you? And then considering some strategies to help you ease into college life. So can you take a reduced course load or attend part-time, especially even the first year? Might be beneficial. So looking at the options of what is considered a part-time versus full-time students, and what is available to you being a part-time versus a full-time student. And then being part-time might just allow you to do other things to take care of yourself. Some people may need to make the decision to stay closer to home if that's what where all their supports are, and that's what's going to help them be successful. That's not for everyone, but it's just an option to consider when seeking out this care. And thinking about how you can adapt your schedule to fit your needs. So there is more flexibility in post-secondary in terms of considering your classes. So some people like to just have small amounts each day. Some people like to cram it more into a couple days, and then having a few days off to help manage that course and what's required. And then we also now have a lot more option in terms of either in class or online delivery. And so whatever is more successful for you. The other big one is reaching accessibility services. So knowing what accessibility services has to offer you at that particular post-secondary institution, and then being open to sharing your experience and learning along the way. So yeah, each individual has a unique experience with their sickle cell and how it's influenced your experience. It might be important to kind of share that with others. So one of the things that is really recommended is registering with accessibility services. So there's been a fair few times where I've worked with different individuals and their sickle cell is well managed, and so they go into post-secondary not being aware or not thinking that they need to register. And unfortunately, later on, we've had to kind of backpedal and register with accessibility services, which is a lot more difficult. there's just not the same understanding. So being proactive is really important. Usually it's recommended about 2 months in advance, if you're able to reach out and connect with them and start that process of connecting to accessibility services. If not, then, you know, as soon as possible. You don't want to be leaving it to the first day of school and trying to register, because they want to make sure we establish what's best for you. So most or all publicly funded colleges and universities operate some sort of accessibility services. They may have different names, but it's the same sort of idea there. So with it, usually what happens is you apply either online or in person. A lot of the applications now are online, and there is a medical component to it. So you will need some documentation from your healthcare team to support that, and most are pretty flexible in terms of providing that documentation. And then with that, the accessibility services create a letter of accommodation that addresses that particular person's impairments and how to best support them. So then this letter is then communicated to your professors and instructors, and they will only know what accommodations that you will receive and not why. That is up to your personal decision as to if you wish to disclose more. And if so, contact early. Sometimes it's better to have that conversation with them prior to, so that they have an understanding of what's going on. And then given that each individual student's needs are unique, they are individually based. So no two students with sickle cell disease are going to have the same accessibility plan. It will be individualized to you and what's needed for you. So these requests, like I said, each student needs to submit the documentation. And then the services will provide you reasonable accommodations or supports. They assist in communicating with faculty when needed about your disability and other required accommodations. And then they provide information regarding policies and procedures, rights and responsibilities as a student with disabilities, and accessing different formats upon their request. They're kind of there to stand up and support you throughout your journey. So there are different types of accommodations that are offered to students. So there's teaching and learning, which might be note-taking. So if you have to miss a class, you're unable to attend, there might be note-taking available to you so that you have more thorough notes for that missed lecture. Assessment and evaluation. So maybe you have private space for exams. So there's also timeline adjustment. So if you are unable to make an exam for whatever reason, whether it be an admission or something like that, it's working with the for the professor and also the accessibility office to accommodate that. Environmental, so strategic seating. Do you need to be placed somewhere else to kind of help you have access to different areas? And then also any services and support, so alternate formats of text, assistive technology, those types of things. So types of supports offered. So most post-secondary offer some sort of summer transitional orientation program. I highly recommend getting involved with that. It is really important in that journey of transitioning to post-secondary. Appointments with a learning strategist, I've also recommended this to a lot of people. I find it really helpful when customizing that journey to post-secondary. Connecting with peer mentoring, which is a part of the process and aspect of post-secondary life. There's lots of individuals and lots of things to get involved with, so peers have great information and knowledge to offer you. Tutoring services and academic support, and then support or social groups. So one thing unique to sickle cell disease is that not only are we looking at those things, but we also look at managing healthcare away at post-secondary. So being proactive, so working with your healthcare team and your family and making a plan on how you will take care of yourself if your symptoms flare up when you are away or you're having ongoing challenges. Thinking about how you will access helpful interventions and get to appointments. So although we have many that come to us and their college and university might be within our town, but they're still a bit of a barrier to get to the hospital. So working with them to establish, does your post-secondary offer a bus pass that will allow you to get to the hospital, and navigating routes and things like that, and just being proactive in that approach. Planning for success, so knowing that your symptoms can zap your energy or limit your physical function. So make choices that are likely to manage your health as easy as possible. So for some, that is picking a residence hall that's closer to essential places. So I know particular one of our universities, they have an underground tunnel that you can get to classes, and especially in winter with some of my patients that cold triggers symptoms, we work with getting a parking spot close to where the tunnels are and accessing those tunnels so that they're not exposed to that like dampness outside and the repeated cold when getting to class. And research what's near you, so not just like in the post-secondary, but also the town that supports it. There's usually lots of unique options there, and might be a great way to get involved. So there are some sickle cell specific challenges. So accessing the emergency room in a different city or province can be challenging. So making a plan, like we had mentioned, on where to access care and supporting documents to provide. So depending on where you are going to school, there might not be a comprehensive sickle cell disease center there, and there might be a great lack in knowledge at that health institute about how to treat. So coming prepared with a plan of action and working with your current provider is really beneficial with that. In particular with sickle cell, the frequent appointments that can happen can also interfere with classes and can impact the physical and mental load put on our sickle cell disease patients. So planning ahead to get that note taking when you're missing and working with the accessibility office. As previously mentioned, there's not always that coordination of care that happens the same way in pediatrics as it does in adult care. And so there might be frequent appointments. So just working so that you can be successful in both your healthcare and your post-secondary, because sometimes it's really easy to put a focus on one and forget about the other, but they both need to be balanced within your journey. And be aware of how you're feeling and assess how you are managing your stress. Obviously, we know with some individuals that can lead to more complications. So just being self-aware is really important. So this has been adapted from the red blood cells disorder program at UHN. They have a really great blog/website that they provide resources for patients living with sickle cell disease. And so this is a really great resource from them. So prioritize your wellness, ensuring that your student insurance covers your care and medications, which in particularly really impacts our international students, because sometimes the individual insurance plans aren't always great at providing the best care. So being aware of that prior to connecting with your school services and resources. If you're able to, getting connected to a comprehensive care center. So again, there is an aspect that we, I know at London, really work with what we call a shared model of care. So if we have individuals from different areas, whether it be Niagara area that are working with McMaster and ourselves create a shared care model so that they are getting supports while they're in the London area for school. And I think that's really beneficial to students and something that's encouraged if you're able to get connected to a comprehensive center. Like we had mentioned, registering for accessibility services, and then accessing settlement services if you are an international student and needing those services. Some just additional tips for being successful at post-secondary. Carry important medical information with you, so a list of your medications, any sort of medical summary, and a hematology team's contact information. So if you have to seek emergency care, you sometimes aren't able to articulate this information for yourself. So if you have documents that can support that, it makes it easier. Even like the contact information for your hematology team, then they know who to reach out to and who are experts within your care. So again, we mentioned managing that stress, practicing healthy habits, staying hydrated, dressing warmly in cold weather, and getting plenty of sleep. Sleep is a big thing as a post-secondary student. You have lots of conflicting things that can impact getting sleep. And so just trying to make that a priority as much as possible, being proactive, and taking advantage of any on-campus resources. And I'll wrap it up with just some resources that are really great for patients. So obviously SCAGO, we wouldn't be here today without them. They have a lot of great resources to support patients with sickle cell disease. St. Jude's Hospital within the States also has a lot of really good educational resources that can be accessed for patients with sickle cell disease. Dot Transition is the organization that creates a lot of the policies and procedures for creating and implementing a transition plan. And so they're on there. And then within Sick Kids and UHN, they also have the resources like I talked about, the Red Blood Cells Disorder Hub that has blog posts and resources to support you. And then the last one is a big one for post-secondary. It is a transition resource, particularly for students with disabilities. So there is even a little course that you can do there to prepare you. They have lots of facts and frequently asked questions to review and see and get all your answers to any sort of the challenges that you might face. So that is all I have for you today. I wish many of you the best in your transition process and post-secondary, and know that there are lots of resources to support you.
Wow, that was a wealth of information, Stephanie. Thank you so much for going through that comprehensive presentation. I really appreciate it. I took away a lot, and I have some questions, but I'll save them for later during our Q&A. Next
great.
up, as mentioned, the information or the flow of information does not stop there. We have Julia Millington, social worker and transition program coordinator at McMaster, who's going to give you some insight into expanding access to programming and supports that are available. Over to you, Julia.
Thank you so much. All right. Hello, everyone. As Delaney mentioned, my name is Julia. I work at McMaster University, and I'm here to share a little bit more information about transitioning with confidence to post-secondary education. A lot of this will echo what Dr. Williams and Stephanie have shared. There's a lot of overlapping information that's really important. So throughout this presentation, I've also included QR codes that you can scan with your phone to visit the different resources and websites that I'm speaking about. I find that often the more we share it, the more questions may come to your mind afterwards of things you hadn't considered before. So if you take away anything from my presentation, it's that there are lots of resources to support you and lots of people that really care. Okay. So before I begin, I'm going to just share a note about language. The term disability is used a lot in the post-secondary space. We will talk about accommodations for students with disabilities, supports for students with disabilities, offices for students with disabilities. And the word disability can be a little bit of a confusing statement because students sometimes identify as having, for example, sickle cell disease or having a mental health challenge, and they don't necessarily see themselves as having a disability. It sounds very serious or like a label that sometimes students don't want to put on themselves. So I'm just letting you know that we will be using it almost as an umbrella term to describe a variety of experiences students have. Of course, every student is completely unique, and even within different communities, such as the sickle cell community, very unique experiences in there, but it's going to be an umbrella term. So if you hear me say disability, I hope you're not taken aback too much by it. It's just a way that we explain our services and how they are customizable to students of a variety of experiences. Okay, so Stephanie mentioned this a little bit already, but academic accommodations and supports are available for every student at a post-secondary institution in Ontario. Of course, Canada as a country has different provinces, so each province has their own policies, but in Ontario, we all offer similar supports. So whether you attend McMaster, University of Toronto, Mohawk College, Seneca, we're all going to have very similar supports, and that's because we're all guided by the same Human Rights Code and the Accessibility for Ontarians with Disabilities Act. So although I'm from McMaster, I'm hoping that this presentation will be a bit of a broader perspective as well. And one of the resources Stephanie actually mentioned, the Transition Resource Guide, is on the screen now if you want to scan it. It will take you to a web page where you can actually research every single college, every single university in Ontario, and it will show you the different accessibility options and contacts for each school. So it's a really great place to get started, I would say, if you know you're interested in going somewhere, maybe you already have a school in mind, to open this webpage and be able to see exactly where to contact. It'll be at the end as well. So when we talk about post-secondary, the main support we provide is academic accommodation. And this is based on the individual need that's unique to you and your experiences with your disease or your disability. So they're designed really to prevent and remove barriers to participation and access in education. So similar to what Stephanie said, if you're having a hospitalization and you're not able to attend class that day, we don't want you to lose participation grades because of your medical needs. So accommodations are really built in to make sure that you are able to have that full participation, full access to your education. And then it's an adaptation of the learning environment. So, you still have to do your tests and exams, you still have to write your papers, but there are different ways that we can make that accessible to you. So, maybe instead of having to hand write an exam, if you're experiencing a pain flare-up, you could dictate to a software your exam answers. So we still have to write the exam, but there are different ways to do it. And these accommodations are for any student with a disability. And so that includes permanent disabilities such as sickle cell, temporary disabilities, like if you were to break your arm or have a concussion, and then also mental health challenges, learning disabilities, ADHD, autism. Sometimes students will say, well, I have lots going on. I have this, which is my main thing, but then, I also have a learning disability. I also have ADHD. I also struggle with depression. And so we want to make sure that your learning plans are really cohesive and we're taking into account all those aspects because sometimes there are overlaps, right? Like chronic fatigue can be a concern for patients with a medical condition and also for students with depression. So we want to make sure your accommodation plan really reflects where you're at. And then you do not need to have an IEP. So that's a really common concern as well of in high school, my teachers are really flexible, or maybe I was homeschooled or I went to a specialized school and I didn't have an IEP, and am I still eligible? And so the answer to that is, of course, yes. We are happy to support you here at university, regardless of what your past educational experiences were like. And as Stephanie said, we don't require that medical diagnosis. So we're not looking for, the term sickle cell disease. What we're looking for is just paperwork that explains a bit more of your experience. And we'll get into that shortly. And it can be a bit confusing to know what to expect. And I think this is the number one question is I've heard that I should sign up for this, but I don't know if it's actually going to help me. I don't really know what I'm getting into. And it can be a bit daunting to sign up for something and not know what you're getting out of it, basically. So an academic accommodation covers all aspects of the learning environment. So that's things like tests and exams, as I've already mentioned, but in-class participation. So if there is grades assigned to attending each class, and that's something that's a barrier to you, there's accommodations, as well as assignments. There's extensions for assignments, labs. So if you're going into a laboratory, there are extensions or, modifications that we can make. We can raise the tables, we can change the lighting in that lab, we can give you extra time in a lab, as well as clinical placement. So if you're in a program, maybe yourselves like nursing, physio, massage therapy, and you're doing clinical placements and going out into the workforce, there are also accommodations we can put in place for you there. And so some really common ones that we implement quite often, although they're all unique to you, would be additional time on tests and exams. That's very common. We have an accommodated testing center in our office where students are able to write tests and exams for longer periods of time. We also do have assignment extensions, which can be really helpful for students who may have medical challenges that take away time from their schedules. They're going to appointments, they're having frequent hospitalizations. So then you might need extensions on your assignments, as well as alternate participation, like I mentioned, lecture recording. So sometimes professors can wear a microphone if you're having hearing challenges, or record lectures to be watched afterwards. And then use of assistive technologies, like I mentioned, that dictation software. As well, Stephanie mentioned this, but the ability to take a reduced course load is also very, very common. This is something that I think surprises students when I say, because you're so used to maybe the high school realm of like, I have to take a full course load. I don't get to choose my classes. It's very rigid. Whereas in university, it's much more flexible, obviously depending on the program. Some programs like engineering, we know, are a bit more strict in the courses you have to take. You can't choose as many electives in those courses, but in general, programs are quite flexible in the amount of time it takes you to complete a degree, as well as the amount of credits you take per term. And as a student with a disability, if you're registered with an accessibility office, you're able to take a reduced course load without losing the benefits of being a full-time student. So I would recommend connecting with your accessibility office to explore that plan and meet with them to make a plan on how you're going to complete your degree. But it's good to know that, even if you're taking 2 courses a term, you still get the benefits of being a full-time student on the books, which could be things like a bus pass, health insurance, etc. And so in terms of accessibility supports, it's a lot broader, obviously, than just the academic accommodation part. Our office also provides assistive technology. So if you do require text-to-speech software, note-taking software, alternate formats for textbooks. I mean, in my day, the textbooks were like 500 pages and really hard to carry. So students would get alternate formats to put them on their computer. So it was less heavy to carry around for those with chronic pain. I think it's quite common now actually to have textbooks online. So I'm not seeing as many of those accommodations needed, but should you ever encounter a class where you do have those 500-page textbooks, the accommodation is there for alternate formatting. And then we also do provide learning strategies. So things like studying, note-taking habits, time management, getting good sleep, balancing your healthcare needs with your school. This really is common because a lot of times students will have multiple overlapping diagnoses. So you may have depression or ADHD that really impacts your studying ability, but then you're also compounded with the medical needs of your physical disability. So we work to help students kind of unpack where things are coming from and find different strategies to cope with all of those. And then finally, we have that transition support. So this, like Stephanie said, is at every university and college. I highly recommend participating. That peer mentorship, I think, is so critical to success because you get to meet others who have been through the process of accommodations, that process of self-advocacy. Sometimes there's students who have similar medical experiences to you, and sometimes they're not. But I think there's a lot of commonalities you can find within that disability community that is really such a new realm for a lot of students to find others who have gone through similar things or are experiencing similar things in this new phase of life that I think is sometimes the biggest indicator of success at university is knowing students have that community to support them. And then outside of our office, so beyond the academics, we know that there are quite a few things at play in this phase of your life. One being residence, so where you're living, whether you choose to live at home or on campus. If you're living on campus, we know that there can also be some barriers there in terms of the physical living space, as well as meal plans, for example. So some students will require access to a fridge, maybe for medication purposes, access to a single-user washroom, potentially access to a whole kitchen if you're cooking a specialized meal plan, or it's really just individualized to you. I will say with residence accommodations, that is a separate process from the academic side. So sometimes there is different documentation required for that, and there may be limited availability. Many schools in Ontario do offer guaranteed residence, so you would likely have a space, but unfortunately places like McMaster do not have guaranteed residence. I know that was an issue for the University of Guelph this year as well, not having guaranteed residence. So when you're planning for your post-secondary school, definitely consider the living arrangements and whether or not that's guaranteed. As well, on campus, we at McMaster and at other schools would have counseling and medical support. I think the counseling is the most utilized service at our campus. We offer one-to-one counseling and group therapy appointments. So sometimes that group therapy group can be really helpful. There's one, for example, on embracing neurodiversity. There's one for managing anxiety. We have a DBT skills group. So there's just lots of ways to connect with students and a therapist in that group format, which can be really helpful for sharing. And then there also, of course, is the medical supports, although I always put the caveat on this of this does not replace your medical care that you are receiving, and you should absolutely be planning to have medical care outside of whatever university or college you're going to. It would not be sufficient level of care. It's similar to a walk-in clinic, so you would see a different doctor every time, they wouldn't have your medical records, and they're not able to provide that ongoing support. So it's, it's more of a thing for a student who, for example, gets the flu in their studies, and I would recommend they go to this walk-in clinic, but I wouldn't recommend it for ongoing chronic medical needs. As well, each campus would have academic advising teams. So these are the people that would work with our office to do some alternate degree planning, alternate course loads, and support you if you were to ever to take a medical leave of absence for a longer period of time, maybe taking a break from your program for a year or two. Definitely stay in contact with us. Don't just walk away from the school. There's ways that we can for you to take those breaks when you need them, and that you still maintain that good standing at the institution. And finally, we do have career planning resources, and this is huge for students with disabilities because there could be so many barriers to finding accessible employment, knowing what kind of roles are well suited for you, that interest you, also knowing how to advocate for yourself and navigate disclosure in the workplace. So this career resource at McMaster, we have one specifically for students in our office, but we also have, of course, the general career resources, and I highly recommend it. They even encourage students to reach out in first year, which I know can seem strange because you're potentially at university for 4, 5, 6+ years. So it seems strange to reach out as a first year, but really their goal is to help you build your resume, to have volunteer experiences, on-campus work experiences, to grow that portfolio. So by the time you graduate, you can really market yourself well. Some similarities and differences between high school and university. QR code on this screen goes to the McMaster website where I've written this out in much more detail. But some things to explain. So in high school, if you had an individualized education plan, that would transfer automatically between elementary and high school. Whereas in university, that documentation does not transfer automatically, so we don't get those records from your high school. You will need to reach out to the accessibility service wherever you go prior to your studies to let us know you're coming. In high school, accommodations can be based on teacher recommendation, and they have very flexible documentation requirements. In university, accommodations are based on recent documentation of disability and those functional impairments. In high school, the parents are often primary contact for your medical appointments, for your IEP planning. Teachers will contact them, guidance counselors will contact them, whereas in university, the student is the primary and only contact for information. So the student has to reach out to our office. We cannot contact their parents. We cannot report back to your family, anything like that. You as a student are the source of all the information. And then in high school, a big difference would be that guidance counselors, resource teachers, etc., would reach out proactively to provide support. And similar to what Dr. Williams was saying, in university, as an adult, you are the one making the appointments. You are the one reaching out when you recognize you need support. So that can be a big change. And I know that's a bit scary for students. They'll get the feeling of like, well, no one here even cares about me. No one here is even reaching out to me. And it's just a bit of a different approach to care. And so, we really do want you to succeed. We really do want to cheer you on, but we don't know you need help unless you reach out to us. So if you ever notice that you're struggling, or maybe you need some guidance, just reach out to your accessibility office wherever you're going. We'll make sure you get connected. And in terms of documentation, this is a huge question I get. What do we need? Folks like Stephanie and transition navigators and your healthcare team will make sure you have the documentation you need from their end. But in general, we're looking for things from within the last 5 years. So recent documentation, not from when you were a toddler or, in grade 3. And what we're looking to establish is the functional impairment. So, knowing you have sickle cell doesn't really actually give us a lot of information, but knowing you struggle with chronic fatigue, especially in the evenings, knowing you struggle with pain, maybe you struggle to hold a pen and write for prolonged periods of time, that's the sort of information we're looking for. And we recommend that you work with your medical team to gather that documentation when you know you're graduating high school and considering post-secondary, although there are specific forms that may be required by the school you choose. So good to gather documentation on your end, mostly so you can look at it and know how to advocate for yourself, and then also reaching out to the school you choose to find what's required. As well, if you're pursuing a residence accommodation for your living situation, there may be different documentation that's more pertaining to the living environment versus the learning environment. So next steps, when to reach out to set up supports. So applications for universities are in the fall, so between October and January to apply to your school. I recommend once you've applied or as you're applying, connect with the accessibility office. Sometimes just to get a feel for like who's going to support you. What's the energy like when you reach out? Are they really welcoming? What's the process going to be from there? Gather documentation, reflect on your needs in this new learning environment, work with your navigating team, your medical team, and then accept your offer of admission to your post-secondary school between January and June. Once you've accepted your offer, you can then complete the intake paperwork, which is often online. I would say like every school I know has the online intake paperwork, so you don't physically have to go into the school office. And then you'll arrange your accommodations appointment. I recommend doing this June to July, so that in August you can participate in all the fun summer transition programming, and you'll begin your classes in September with everything set up, so you're not experiencing any gaps or delays in the support that you may need in your classes. One of the last slides, I promise. So funding, really important to know that there is significant scholarships available for students. The website I recommend is disabilityawards.ca. There's a QR code on the screen to that website, and it is a great way to sort by province, sort by disability type, and to find scholarships that are applicable to you. As well, each school will have their own scholarships database. At McMaster, it's called Award Spring, and there are millions of dollars given out through Award Spring to students. So make sure you're looking at your school website and this Disability Awards website as well. I also need to mention OSAP. So if you're an Ontarian student, you are eligible to apply for OSAP, Ontario Student Assistance Program. It is based on, family income status. So not every student will qualify, but I recommend every student apply regardless to see if you are eligible, because sometimes you might be surprised. There's a disability verification aspect to the OSAP application. And if you qualify for funding, you are eligible to receive the Canadian Student Grant for Students with Disabilities, which last year was over $2,000 per student. And then if additional services or equipment are needed, there is a bursary for students with disabilities. So this can be used for things like counseling, tutoring, buying an iPad, for example. So there's lots of funding available through our office, but you do have to apply to OSAP to sort of unlock that funding. And the OSAP application opens in the spring before you start in September. So it's open right now, for example. And transition programming. So this is my favorite part of the presentation because this is my whole world, is transition programming at McMaster. So each school has a different name for the program. Ours is called MaxStart. It's a free program for students with disabilities or accessibility needs. And it's really designed to help you learn to self-advocate for yourself in this new environment, to set up your academic accommodation plans, and to do some skill building. So our program is virtual, which makes it pretty accessible to you regardless of where you live. We have students from inside the province, outside the province, and international students participate. The QR code's on the screen if you're interested in seeing the specific workshops we're offering in MaxStart this summer. But in general, we're having some assistive technology training on free tools such as Microsoft OneNote, read and write software. We're also going to be going over Microsoft Outlook and To-Do. We're going to be talking about note-taking and study strategies, how to write university essays and assignments. We'll have guest speakers from across campus talking about things like, taking care of yourself and wellness, mental health on campus, library and research strategies, guest lecture, as well as those online learning modules for additional content. And of course, we'll have weekly peer support drop-ins. So I'm super excited. This starts actually next week. All right, so I'll leave it on this slide, which is all of the resources I've talked about. So on the left-hand side is max start information. Then there's the differences between high school and university. There's also an academic accommodation guide that you can scan. That will explain the actual steps of the process. So intake form, uploading documentation, meeting your coordinator, and going from there, as well as the types of documentation required. And then on the far right is the Transition Resource Guide School Checklist. I would love for all of you to check this out. It really walks you through how to pick a school that meets your needs. And it's something I give out every fall when students are coming to McMaster for tours. I just give them out constantly because I think it's so important to be able to cross-reference all of the programs you're interested in, all of the support offices, all of the residence options, the food plan options, whether or not the school has a tunnel to avoid the cold, whether or not they have a free bus pass, whether or not they're close to a medical institution. So highly recommend Transition Resource Guide. And of course, my email's on the bottom, and I'm happy to take any questions afterwards as well.
Wow. And thank you, Juliet. I mean, I have a ton of questions, but I don't want to jump the gun. I have to follow my own instructions and wait to the Q&A period. But this has been so great. I really appreciated how, to your point, there's been some doubling down on some really important insights from our earlier presenters. But to your point, you really had a nice, distinct presentation. And I already see some questions in the chat box, but we can get to those shortly because I do not want to undermine our last, but certainly not least speaker, Fitz-Ann Howell, who will be giving us a bit of a personal touch and then sharing some of our own lived experience as well as some items that we definitely feel folks on the line should be aware of. So Fitz-Ann, without further ado, please close us out.
Wow, not me getting the heaviest portion of the presentation, but okay.
You got it. You got it. You got it.
As you said, my name is Fitz-Ann. I am a patient advocate. I am the chairperson of PAC. So I sit on the Patients Advisory and Advocacy Council. I always get that wrong. So if there's ever any questions or patient needs that need to be addressed, you can definitely reach out to us and we'll try our hardest to get them the resources they need. But I have been living with sickle cell forever and a day now. I was born in the 90s, which, you know, I'm aging myself, but I was not granted the luck of having transition programs and all of these accommodations and the things. So for me, the one thing that I will focus on, I'll probably go back and forth. I'll do hospital as well as post-secondary because I did both. And I was transitioning around the same time for both. So for me, I went to SickKids. And I also am now at Toronto General, UHN Hospital. And my transition sucked. I'm gonna be honest. I'm gonna be 100% honest. It was horrible because I don't think they had started that transition program when I was leaving. Essentially, I was transitioned over when I was about 20 because the UHN red blood cell clinic was not ready to take more patients. So I got to stay. It was a privilege. I got to stay at SickKids a lot longer than I should have, and I loved it. It was great. But transitioning over, I hated it. For example, all of the things that Susan touched on with the not trusting your staff and your medical team and the concerns of, will I get the same care and will they listen to me? I had all of those questions. The lucky thing for me is I grew up in a very, very strong Caribbean household, and you're taught to speak up from a very early age. You have to speak up. My mom's one saying is closed mouths do not get fed, so you must speak up. And she started transitioning me before I was transitioned. So essentially, at 16, I was taking the train to SickKids and doing my own appointments by myself. I was talking to the doctors by myself. I was working on my care plans by myself. And I'd have her on the phone, or I'd have to call her afterwards, or wait till I get home and brief her on everything. And she would always point out, did you ask them this? Did you do this? Did you do that? And it kind of started to rewire my brain as to, you're not a child anymore. You got to figure this out for yourself. And I think that's the hardest part of transitioning. The going from mom and dad are doing everything to I'm on my own, figure it out. And the good thing about my parents is my mom is like the risk evaluator. Everything has to be done a certain way. My dad's the very free spirit. But when it came to my care and transitioning, they were very stern on, you go in there, you ask all the questions. There's no such thing as a stupid question. It's your health. What do you want? And I think that was the turning point for me. So when I got essentially thrown into the adult care, it wasn't hard for me to advocate for myself, to speak up for myself, to ask the questions that no one else wants to ask. And the thing about adult care is once you get there, the doctors are, I know it, I know everything. You don't know anything. And you have to find a way to combat that. And I have a friend who says it best. I believe they're in their 50s now, so they've been doing this a really long time, a lot longer than me. But you have to learn the power of negotiation. And it sounds businessy and it sounds like a contract and like, but it essentially it is. You're going in there with, oh, at SickKids, they used to give me however many milligrams. Can I not get that here? At SickKids, my doctors used to follow this care plan. The doctors at the adult facilities, they don't know that. They may know, but they don't want to do that because all of their other patients have followed their care plans. So you have to learn how to, okay, can we try it this way first? And if it doesn't, we'll tailor it together. Can we work on doing XYZ first? And then we'll talk about the next steps. But I just need whatever you need. And everybody with sickle cell is different. All of our needs and what we go through are different, regardless of if we're on the same, I have SS, you have SS. Your life is different than mine. So your needs may be different from mine. So the fact that most adult care facility practitioners, when I transitioned, all had the mindset of, this is what all my other patients did, so you're going to do what my other patients did, is a roadblock because I'm not your other patients, right? So as I said, for me, going into the adult facilities, I had to advocate. And they knew me as the angry Black woman, and I was okay with the stereotype because it's just what you have to do when you get to a place where no one is listening to you, where no one is taking you seriously, where they feel like you know nothing. Because usually 9 times out of 10, I have friends that have come out of like child pediatrics and gone into adult care and they know nothing about their health. And I understand that because, you know, you've never had to do it. But as I said, I was forced to do it. My parents gave me no other option but to do it. So today I can walk into Toronto General, walk up to my hematologist and be like, this isn't working. We need to try this. We need to do something. And they will listen to me because they know me as Fitz-Ann is not going to take no crap from no one, essentially. So that transition for me was very difficult, but I've come to a point where it's working. And luckily I had my parents, as I said, to force me to advocate, to force me to understand my care. At 12, I knew how many milligrams I was taking. I knew what I had to take. I knew what time. I knew how it worked. And my teachers had to just accept it. I knew I had to walk with a water bottle and why. I know that when I walk into the hospital, I need Dilaudid and I need an IV for this and that and however long. I need oxygen. I know my care plan and most of them don't. And I believe that might be the indicator. That's the trigger. That's the borderline of like, okay, you're good or you're not good. And essentially going from pediatrics where you're like, well, it's in my chart, they know it, and coming into adults where you're working with 50 different doctors at a time. You don't know who you're going to see today. You walk into Emerge, they've never seen you before, right? And you have to be able to advocate for yourself. I can walk into Emerge right now. I have sickle cell, I'm SS. I know what I take. I've taken this in the last 3 hours. I need this. I need oxygen. In 20 minutes, I've been in crisis for however long. And you just got to be able to do that. I was the child that walked with her immunization card in her bag at 10. I had my health card at 12. So you kind of have to get to the point where you're taking over. My mom used to sit in my appointments with me, and when they ask her questions, she's looking at me like, so answer, right? And at the time, I hated it. But now, looking back at it, it's something that we need. So the transition for me was terrible, but we made it. We're here. And I'm glad that now they have the transition programs and all of those in place, because that would be my only suggestion. Start it early, get them to know and understand what they need and how to do it, because that was the downfall of a lot of patients. I have friends now that don't have hematologists because they didn't know how to do that. They didn't understand, and they don't like the doctors that they have now. So they kind of just said, screw it, I'm gonna figure it out on my own, because they never learned how to advocate for themselves and negotiate and work together and build that relationship with the care teams. As for post-secondary, when I was transitioning, my parents did give me the option of taking a year off to kind of sort things out one at a time, which was helpful because I was getting sick every 2 weeks of every month, ending up in hospital. So they gave me the leeway to take the time off. Let's transition you into adult care, figure out what they want you to do, and then we'll take school seriously. So I was able to take a year off. So I didn't have to do them both simultaneously. But I did have to do it at some point. And when I went to Humber, when I did my first program, because I did about 3, I did the bridging program because, of course, high school, you miss classes, you miss assignments, and your grades are trash, and they kind of just give you the diploma to get you out. They don't want to deal with you anymore. So I did go through that, and I took the bridging program. I did that without accommodations. I did that without knowing that there was an accessibility center at my school. The only way I figured that out is a friend of mine said she has a learning disability and needed help. So I started to think, I think I had a learning disability, but I wasn't sure because no one had ever taken the time to point these things out to me. And I was fortunate enough to go into the center day one, say, I think I have a learning disability or something and I need help. And they funded the entire thing. I believe they got government funding, and if they find something, you don't have to pay. If they don't find something, you will have to pay. Luckily, they found something, so my wallet was protected. So I didn't have to pay. They also provided me with a laptop. They gave me the read and write technology on the laptop as well, software. I was able to get all of the things because of the learning disability that they found. And after doing all of that, I walked into my counselor's office, my specific caseworker, and I said, I have sickle cell. Can you help me with that as well? I don't know if you know what that is. And I had to give her like the rundown, and she's like, I think you are my first sickle cell patient in school. Let's figure this out and let's put it together. So essentially, I may have been her first. I may not have been the center's first, but I did set up my own program for accommodations and what I need. And all of my professors going forward were very understanding that Fitz-Ann's gonna take days off. When it's cold outside, don't expect her in class, but have notes prepared. She's not gonna make all the assignments. It's just how it works sometimes. So I did go through that, and essentially I wrote my own accommodations program. And I think now they have a lot more sickle cell patients and advocates there. So sort of the pioneer, and I wear that crown humbly. But essentially, you have to, it all ties back into knowing how to speak up for yourself. You have to know how to speak up for yourself. And without that, you're not going to get anywhere. I won't take any more of your time, but the one thing I want to leave you with is when transitioning, understand your health, even if it's just your health, because I have sickle cell friends that talk to me today and I'm like, I don't know what you do. I don't understand. But understand your health. If you're a caregiver, understand that you have to let go at some point, and you have to let them learn, and you have to let them understand. And open your mouth. Nothing is stupid, and there's no such thing as a stupid question. Even if it sounds like you should already know the answer, ask the questions. There's nothing wrong in asking questions, because at the end of the day, you don't know what you don't know. So I will leave you with that. And
Well, I mean, on behalf of everybody here, Fitz-Ann, we thank you. I think I really want to double down to all the caregivers online, all the moms, all the fathers, sisters, brothers, all those supporting ones in your family who are living with sickle cell disease. Let Fitz-Ann be a testament to all of you that the the information, the empowerment that you give to your little ones or those transitioning is unbelievable. Because thank God for your mom and dad, Fitz-Ann, to have given you that, to empower you. I love how you said it. You hated it at the time, but in hindsight, you can see how important it was what they were doing. And sometimes, certain lessons can't be told. You have to live it to understand what it meant to do. So thank you for you. Thank you for your mom. And thank you for your dad for building an awesome champion that you are. So we've now entered into the Q&A section of today's webinar. We have a bunch of questions. I'm not going to pull up any more slides. Let me just get right to it because we're about 18 minutes until the end. Okay, the first question was, I think, during your presentation, Dr. Williams. It said that, within one of the bar graphs you'd shared, it mentioned that 96% live past 18. This person's asking, is that globally or just in North America / or in the Western world in Europe?
That unfortunately is reflective of US data. It would be probably comparable for Canadian and Western European nations and children receiving sickle cell care there. It would definitely not be reflective of other parts of the world. So not reflective of the majority of the regions of the world where sickle cell disease is prevalent, unfortunately.
Perfect. Okay, that's unfortunate, but thank you for clarifying that for us, Dr. Williams. Next question comes from a colleague, Sandra. Would it be possible to hear more about support for international students and ways to help them meet gaps in coverage for essential medications, non-urgent or routine medical visits, etc.? So I think Stephanie and Julia, you might be best supported to respond to this question. Maybe I'll start with you, Stephanie.
Yeah, no problem. So with that, in terms of supports for international students, it depends on each institute. So I know myself, depending on what educational institute the international student is attending, there is either better or worse coverage, unfortunately. And it's something that I know SCAGO is working on. I know there's different members of SCAGO that are trying to get better standards and comprehensiveness across the board so that it's not an individual institution thing. But it is, and it depends on the insurance program that they offer. And so we usually find, unfortunately, universities have better coverage for those types of things. And college, just depending on the insurance provider they have, is not as great. The problem is that it is up to the individual insurance in terms of coverage. And we've looked at many different routes for different patients. We've tried to look at even, just external coverage for them to buy and purchase to cover them. And there is a lot of times they won't cover because sickle cell is considered a pre-existing condition and the coverage isn't comprehensive, or if it is, it's quite expensive. So it's something I look forward to better support our international students, but I definitely think it's a gap right now, unfortunately. And I appreciate SCAGO support in helping to support these patients better.
And just to echo what Stephanie said, having worked at a few institutions, there are differences in, we call it UHIP, so University Health Insurance Program or Plan, and it's different depending on where you go, and you don't really know what the specifics are until you're a registered student. So I recommend, of course, working with an advocacy group, because there may be other people who have been through it that can share their experiences. Demystify the process a bit, but I know that there are a few organizations that are really advocating for a change. So I'm hopeful that in my career there will be significant changes to that process.
Duly noted. Something for us to take back and see how we can continue providing some paths forward. But thank you, Stephanie, Julia. Continuing on, I think this might go back to you, Julia, but are psychological assessments available at the post-secondary level if a learning disability is suspected, but was not diagnosed at an earlier point, and can also be a resource to cover the cost for this test?
Great question. Speaking, sort of Fitz-Ann, you shared about this a little bit. There are resources. So first would be to reach out to the accessibility office. We can do some interim planning to put accommodations in place while you're being assessed. We also do have a network of folks who do assessments through the Regional Assessment Resource Center, RARC, whose resources we've shared earlier. They do it for a reduced cost, and it could be up to no cost, depending on your OSAP eligibility and what they find on the assessment. So if you are diagnosed with learning disability, typically there's no cost to the assessment. It can be covered by OSAP. So I recommend first reaching out to the school. We can put those interims in place so you're not going without an accommodation, and we can figure out what's going on. Sometimes students will assume they have a mental health challenge, and it turns out later it's ADHD or it's autism or it's a learning disability. So having that assessment can really help unpack the different pieces of the puzzle.
Perfect. I'm going to throw in a bit of an audible, but I have a question that I'm dying to ask, and it's to you, Dr. Williams. You made mention that there was a survey conducted of internists who were not fully what's the word? They were insecure about delivering care to individuals living with sickle cell disease. The question is, was there any rationale provided as to why they felt that way, or was there any depth, more digging to understand what they need to fill that gap?
Yeah, I'll put it in the context of part of the issue with care provision to adult patients with sickle cell disease is that there's often a lack of sort of trained hematologists to take that on. And so there's been a lot of thinking in the US and other countries as well as to who is the right person and who can be the right person to deliver care. Do you actually need a hematologist? Because if you think about it, it's a blood disorder, but it affects every organ system. So it doesn't necessarily have to be a hematologist, it just has to be someone who is competent, interested in managing these patients. So hence the sort of query to what other sectors of the medical world could be engaged in providing sickle cell care. And so this was really sort of a query, a questionnaire study that was sent out, it sort of posing a theoretical question, like, would you be comfortable as an internal medicine trained physician to look after cohorts of patients with sickle cell disease to kind of establish what that would be as a baseline in the community. And interestingly, or surprisingly, or maybe not surprisingly, that was the response that folks did not feel comfortable. And I think you could postulate as to why that might be. Probably the biggest reason would be just lack of familiarity, to be quite honest, in terms of looking after that patient population. And as well, people always talking about funding issues in terms of care for patients with chronic disease is often not adequately or well funded, right? In terms of reimbursement, particularly if you're outside of a publicly reimbursed system. And so that would be something striking in the US. May or may not be different in Canada because we have our own issues with our healthcare system as well.
Thank you so much for that, Dr. Williams. I know we have a couple more questions, but Fitz-Ann, you've been quiet, and I really want to touch on a point you made during your section in and around the power of negotiation. So that didn't seem to be something your mom had bestowed upon you. It seemed like you kind of arrived at that skill you needed once you entered adult care. Any other tips you can give folks about when to push and maybe when to recede?
Yeah, so my parents didn't have to negotiate because the pediatric system, they kind of work with you regardless. Which is what we found, but I've heard other things about sick kids in the 80s. Not gonna talk about that.
Let's not go
But
back.
not my place. But I think you have to negotiate and you have to be willing to push at all times.
Okay.
But what I will say is most times when you walk in, assume that the doctor is I know more than you automatically off the bat, because usually that's what's going to happen. I've had maybe like one or two doctors actually sit down and get to my level and like, what do you need? What shall we do kind of thing? But 9 times out of 10, they're going to walk in. I'm going to give you this. This is what's going to happen. That's how it's going to work. So always walk in, I don't want to say ready to fight, but be ready for some form of confrontation, and always be willing to push. It's about knowing how to push. So my mom has a saying, she says it all the time. It's not what you say, it's how you say it. Because if I go in hot and I say, no, I want this, I need this, they're going to automatically shut down. So you're always going to have to push. There's not really going to be like that receding and like, okay, I give up kind of thing.
Yeah.
You're always going to have to push, but know how to push. So knowing like, okay, he's not going to back down and he's not going to give me the dose. Okay, how about we go, okay, I normally take 12, you want to give me 9. How about we start at 10? And then see how that works, kind of thing. And like make it seem as though you're not fighting, you're willing to work with them, and because it's a relationship at the end of the day.
Right.
So
beautifully said. No, I'm glad I want to make sure you had a chance to unpack that a bit further. Okay, back to, this is open to maybe it's Stephanie and Julia again, but parents often struggle with their changing role and level of involvement in care and access to information as students approach the age of 18. So does any part of the transition model address the caregiver and help them negotiate this piece of the puzzle? You know, the need for advocacy remains after 18, as Fitz-Ann has currently mentioned, but not all medical or educational institutions automatically provide the care or support to caregivers. So maybe I'll start with Stephanie.
Yeah, it's a great question. It is, in terms of when you look at research for transition processes, there is involvement and strategies provided to caregivers to support these individuals that are approaching this transition. And again, that is individualized to the person themselves and the families as well, in terms of what their involvement looks like, because I have many who are 23, 24 that still have parents involved, although we encourage our individuals to be independent and not need the additional advocacy. That's not always realistic. So it's just working within the healthcare system and the privacy regulations that are out there, that we work with the individual and get their consent if that's what they wish to have someone there to advocate on their behalf, and making sure that privacy is taken care of. And as long as that's done, we're happy to have these members there. They are usually a great resource, especially in emergency situations where the individuals are facing these concerns that they can't always speak for themselves, that they need someone there to speak on their behalf. And so it's great to have caregivers be there to support them.
Beautiful. Julia, anything to add?
Yeah, just echo that. At the university level, parents are often surprised by the sort of closed door nature of it, right? Like you're supporting your student through high school and all of a sudden you reach this like roadblock. I will say, although the student is the center of our care, we would never share information without their consent. A lot of the time students do provide that written consent, and we're able to involve family, parents, caregivers, sometimes even folks like Stephanie will join our calls to share a little bit of the background and help that student advocate. So we try to keep people involved if the student wishes. And then through the summer transition program that I run, we do have parent workshops as well. And sometimes parents being able to express their concerns and meet with other parents can be really helpful. And just feeling that sense of trust with giving that student over to the institution in a sense.
Beautiful. Julia, we're going to stay with you. During the student touring week, do universities collaborate with associations such as, you know, SCAGO as reflected here, to like have a table that helps recommend, or not recommend, but profile particular conditions students might?
Would you like to, Delaney?
I mean, it's I didn't ask the question, but I'm loving it for that very reason.
Yes, so each school will have a variety of open houses in the fall. McMaster has 2, one in October, one in November, right around the time of applications. Typically, all of the different departments come out and have booths. Our office has a booth, and we will share resources, like I said, from the Regional Assessment Resource Center. Sometimes we'll share resources from different groups, more specifically students who might need assistance from CNIB if they're blind, or deaf, hard of hearing students. So we do partner with some special groups to share resources. So Delaney, I'm not joking. Send me some resources I can put at our booth so that students can feel that connection, because sometimes seeing yourself represented and shared just makes all the difference.
Beautiful, Julia. We will definitely take you up on that offer. Folks, we're not done yet. I'm just going to launch a poll so we can collect some feedback. So if you have a few seconds, please do submit your feedback by way of the poll that's just been posted. And there's a couple more minutes with our guest speakers. So if you have any burning questions, feel free to pop them in now before our speakers go and enjoy the rest of their Saturday. Julia, one more question. Sticking with you, Max Start. Can anybody attend Max Start, or does it only respective to McMaster students?
Great question. This, I would say, is respective to McMaster students.
Okay.
However, I will put it in the chat again. The Regional Assessment Resource Center, RARC, has a transition program online for all high school students. So even if you're taking a gap year, it's a great program for you, completely free. It covers similar content to Max Start about self-advocacy, writing down your strengths, writing down your needs, the barriers you may encounter, the documentation you need to provide, and then getting used to emailing professors, talking to peers, working with roommates to establish roommate agreements. So I'll put all of those links in the chat, but I highly recommend VARC because they really are like such a cool leader in this space.
Beautiful. Thank you, Julia. Okay. And it was an interesting tidbit. You mentioned, so Stephanie had mentioned it made sense for folks to begin, I think you call it your accessibility plan, getting that turned around to universities, accessibility centers, at least 2 months in advance. And then Julia, you mentioned that, traditionally folks receive their acceptances in and around June. So high school ends in June, school starts in September, you're navigating, getting residency and moving and getting prepped for the transition. And then I know, Stephanie, you mentioned as well that if you bring that plan to universities late, you mentioned some roadblocks might kind of occur. Like if it's after your first year and you now introduce unique accessibility, there's some pushback that folks might receive from the institutions. I was wondering if you could just help us understand what elements can folks begin developing, before they get their university acceptance. And then also, Stephanie, if they're slow, and later to the game, and they do need to actually bring this plan forward at like end of year one, beginning of year two, some considerations they need to be prepared for.
Yeah, I mean, there is no limitation on when you can get registered. That service is there to you whenever. The only problem that I've seen is that I've had students hospitalized and then they haven't registered and they're facing issues with those types of things. So I unfortunately had one student that ended up losing a whole year of schooling because they had failed to register for the accessibility services just because of some really series of unfortunate events. So always like to be proactive. I think it's just a great strategy to have. It's not always easy, but I think when you have the capacity to do that, it's great to start it, even if you think you don't need it. Like I said,
Right.
My particular patient who was hospitalized, they didn't think they needed it. Their sickle cell was well managed. They hadn't had issues previously, and that transition to being more independent, being away from home and school, really threw them some challenges, and they had multiple prolonged hospitalizations that really impacted their education. And most post-secondary do have someone that is their purpose, is to help transition these patients from hospitalizations back into school. There's just sometimes they're limited again on what they can do if the services haven't been established.
Beautiful. Thank you, Stephanie. So folks, I know we're at time. I know there's a number of other questions. Folks are asking for the PowerPoint slide decks and the presentations. We'll do our best to have them centralized somewhere for folks to review, but do know everything you heard today has been recorded. It will be posted on our sicklecellanemia.ca website, so the information is not lost. So if you're joining a bit late or are just seeing the session for the first time at this moment, please know that it will be recorded. It's been recorded and will be posted. I would be remiss if I didn't bring to folks' attention that our upcoming Sickle Cell Disease Summit is taking place August 23rd and 24th. There still exists an opportunity to register. I'm putting the link in the chat as we speak. So for those of you who are looking forward to hearing more insightful conversations like the one you just participated in this morning, also getting engaged and interacting with other sickle cell experts and members of our community, please, please, please do register. We do have a limit as to the amount of folks we can have participate. So the earlier you register, the better. And thank you for those who filled out today's poll. I just want to give one huge, big thank you to each of our speakers. We cannot commend you enough for not only spending the time with us this morning, but also delivering a wealth of information. It was so insightful, so comprehensive. I myself took away so much from it, and I really appreciate it. And on behalf of SCAGO, we really appreciate you. So with all that being said, thank you to all of our attentive audience members. Thank you to our panelists. Thank you to our organizers. I wish you all a lovely rest of your Saturday and weekend and a lovely rest of your summer. And I hope to see you all soon at our upcoming summit. And that draws to a close our transitions webinar. Thank you once again. Take care, everybody.
Thanks, Delaney.
Thank you.